Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody, and thank you, my dear chairperson. And in the next few minutes, my talk will be on the role of adjuvant treatment for resected RCC. This is my disclosure. And as you all know, that definitely in the last decade, we have the treatment of the RCC with what is known as target therapy. And we have a lot of tyrosine kinase inhibitors, and the trials here in the era of tyrosine kinase inhibitor as adjuvant treatment for resected RCC are quite a long list of trials, starting by the ASSURE trial, the ASTRAC, and PROTECT. And as you see from this table, that we didn't have any overall survival benefit, and what we have from the ASTRAC, that we have a disease-free survival in one trial. In the other two trials, where we go for the ATLAS trial or the SOURCE trial, we didn't attain any disease-free survival or even overall survival. And look what are the population who you'll think about to give adjuvant treatment. Definitely, the population is those with high T, high grade, and lymph node positivity. So among this trial, we have the EVEREST trial, where they go for everolimus versus placebo. And as you will see here, the recurrence-free survival is not statistically significant, and the 5-year estimate is 67 for everolimus versus 63%. But when we go to the subgroup analysis, when we go to the very high risk and the intermediate high risk, you see that the curve will separate very widely from the start till the end for the very high risk population, with a hazard ratio of 0.79 and statistical significant p-value 1 alpha-sided. While for the intermediate high risk, as you will see here, the two curves are overlapping each other. So it seems that we can attain some population of patients that can benefit from the adjuvant treatment. This is the overall survival, which again is not significant whether you go for adjuvant everolimus or not, with a hazard ratio of 0.90. So my first take-home message, that the ASTRAC, where they go for sunitinib as adjuvant treatment in resected RCC, it is, in spite of clearly being successful more than other adjuvant study to maintain exposure to sunitinib. However, we have a very high drawback, that we have a 44% of the patient have premature discontinuation of the sunitinib, and this mainly due to the side effects, which was 40% of grade 1 and 2 as mentioned. Also, the PROS, or reported outcome, patient-reported outcome, has been emerged as an important tool for the assessment of patient perception of toxicity, and they have been appropriately used in this study. And again, they showed deterioration in the global health score and the quality of life for this patient population. And what is very amazing also, that at a median follow-up of 5 years, we didn't attain any overall survival benefit or reduction of risk of death in the ASTRAC for the sunitinib arm. And lastly, the current role for angiogenic inhibitors in the adjuvant setting remain very debatable. For consequences, the FDA and EMA have different opinions on the approval of sunitinib as adjuvant treatment. So the FDA have in favor of using sunitinib as adjuvant treatment. However, the EMA is not. And also in the guidelines on adjuvant treatment, it's still divided, that the NCCN guidelines for stage 3 and 4, definitely they decided to go for sunitinib. However, the European Association of Urology is not in favor of using sunitinib. So because of this dilemma, we go to the immunotherapy and whether we can use immunotherapy as adjuvant treatment for resected clear cell RCC. We have the Keynote 564 and we have the 30-month follow-up. It is a multi-center double-blind phase 3 study of adjuvant therapy where patients with histologically confirmed clear cell RCC and going for nephrectomy, they are stratified to go for pembro versus placebo at the usual dose of 200 milligram every 3 weeks for a 1 year, which means equivalent to approximately 17 cycles. And they stratified the patient according to what is known as M0 versus M1 NED, which is a new classification because the old classification used the intermediate risk and the high risk for recurrence. However, here we have the M0 and the M1 who can be rendered M0 by, for example, metastatectomy or whatever. So also we stratify the patients according to the ECOG performance status, 0 versus 1, and US versus non-US. The primary endpoint again is disease-free survival because here we talk about adjuvant treatment, so it is usually the primary endpoint, disease-free survival, and the secondary endpoint is overall survival and safety. These are the eligibility criteria. So we have the histologically confirmed clear cell RCC with intermediate risk to high risk disease, which means any pathological T2, grade 4 or sarcomatoid differentiation N0M0, pathologic T3, any grade with N0M0, high risk disease, which means pathologic T4, any grade with N0M0, or any pathological T with any grade with positive lymph nodes M0. The new term is M1, no evidence of disease, which means that we have metastatic disease in addition to the primary tumor at diagnosis, and you can go for complete resection at the time of nephrectomy or within 1 year after nephrectomy. And these are the disease-free survival as a primary endpoint after 30 months follow-up, which means 2.5 years. As you will see here, it is not reached neither for pembro nor placebo, but look to the hazard ratio, it is 0.63, which means we have 37% risk of reduction of recurrence with a statistically significant p-value, and the 2-year survival rate was in favor of pembro 78.3 versus 67.3. These are the key subgroups according to the disease-free survival. Definitely, we have a better disease-free survival with a hazard ratio of 0.58 for those patients with less than 65 years. For male patients, for ECOG performance 0, for the European Union, much better than North America or rest of the world, and definitely for high tumor grade 3 and 4, much better than grade 2. And also, if you have a PD-L1 status combined positive score more than 1, it is 0.63. For less than 1, it is 0.68. These are the 2.5-year follow-up disease-free survival by recurrence risk. So if you look to the all subgroups, the intermediate high risk, the high risk, and the M1 and ED, we have amazing hazard ratio in the first 2.68, 0.60, but look to the M1, which is rendered to M0 with a surgery to the metastasis, either at the time of nephrectomy or within 1 year, you reach a hazard ratio of 0.68. And here, as you will see, the curves separate as widely as possible from the start to the end. Also, what we have, that if you have a sarcomatoid features, definitely the pembro act much better if you have sarcomatoid or if you don't have, but look to the hazard ratio. If you have sarcomatoid feature, it is 0.54 instead of 0.63 where you didn't have any sarcomatoid features. Also, the overall survival, although for the first approximately 20 months, the two curves are overlapping each other, but they start to separate approximately by 20 to 22 months, and didn't attain for both arms any overall survival benefit, but look to the hazard ratio, it is 0.52, which seems to be in favor of the pembro versus the placebo. Also, definitely the treatment-related adverse events is mostly of immune-related adverse events in the case of pembro versus the placebo. So you can have also some fatigue and some diarrhea and some rash, while for the placebo we didn't have such side effects. Also, the distant metastasis-free survival was in favor of pembro versus placebo. As you will see here, the pembro will delay the time to distant metastasis-free survival versus the placebo. And the time to first subsequent anti-cancer therapy in the intent to treat population again was in favor of pembro versus placebo, although it does not reach the median 50% not reached. However, when you see the curves, they separate from the start till the end in favor of the pembro. The time to second occurrence of disease progression again not reached for both pembro and placebo, but again it seemed higher for the pembro than the placebo. So the second take-home message that adjuvant pembro could be considered for patients with intermediate or high-risk operable clear cell RCC after careful patient counseling regarding still we didn't have any overall survival data and the potential long-term adverse events that can patient take during the adjuvant treatment. And still we are need to look for the overall survival data, and your treatment should start within 4 weeks of surgery and continue up to 1 year. And definitely adjuvant pembro can be offered to patients with M1 NED after complete resection of their oligometastatic disease. These are also the trials with the immunotherapy in the non-metastatic RCC. We have the PROSPER trial where we go for perioperative nivo 1 dose for surgery and then to be followed by 9 doses for nivo versus observation. We have the iMotion adjuvant atezo versus placebo, and we have the Checkmate 914. And if you look here, we didn't, also with immunotherapy, we didn't attain any disease-free survival or even overall survival benefit for resected RCC. These are the PROSPER RCC, where we started with nivolumab at 480 milligram for 1 dose, then we go for partial or radical nephrectomy, then to go for nivo 480 milligram every 4 weeks for 9 dose versus only surgery, partial or radical nephrectomy. Primary endpoint, relapse-free survival. Secondary endpoint, overall survival, safety, tolerability, and quality of life. The PROSPER trial is slightly different because we have 1 dose preoperative prior to surgery and 9 dose after nephrectomy. The study comprised approximately 819 patients, and the primary endpoint, as you see, recurrence-free survival. However, this trial was stopped early by the Data and Safety Monitoring Committee due to the futility of the treatment on the patient health, and the recurrence-free survival have been also similar, whether you go for nivo or you go for surgery, and approximately 20% of the patient experienced the grade 3 and 4 adverse events that could be attributable to the nivo compared to only 6% in the control arm, which is surgery alone, and the incidence of surgical complication were comparable for both. So the PROSPER trial have been stopped because of the futility of the treatment. The iMotion 010, this is atezo versus placebo. It is a phase 3 trial where they go for atezo at 1,200 milligram IV versus placebo as adjuvant treatment in approximately 778 patients with RCC who had an increased risk of recurrence. And after a median follow-up of 44.7 months, the median investigator assessed the disease-free survival was 57.2 months for atezo versus 49.5 months for placebo. However, the hazard ratio is 0.93, which is very dismal and with no statistical significant difference, and no disease-free survival have been observed whether your patient have a PD-L1 positive more than 1 or less than 1, and in overall survival for patient with PD-L1 between 1% and 5%, the hazard ratio 0.92. So again, it seems that we didn't have any prognostic effect of the PD-L1 on either the disease-free survival or the overall survival. In terms of safety, still we have 27.2 and 21.1 of the patient had grade 3 and 4 adverse events with atezo and placebo respectively. The last study was the Checkmate 914, which is nivo-epi versus placebo. And again, as you see, you have the pathologic T2A or B for grade 3 or any grade N0, M0, pathologic T4, any grade N0, M0, and any pathologic T, any grade N1 and M0. And the primary endpoint, again, is disease-free survival, and secondary endpoint is overall survival and safety. The background, definitely, that we have in the metastatic RCC, the CheckMate 2 and 4, that nivo-epi significantly improved the overall survival, duration of response versus sunitinib in untreated advanced RCC. So why not to go for adjuvant nivo plus epi, which is part A and B, and single nivo part B in patients with resected stage 2 or 3 clear cell RCC at high risk of recurrence. And these are the baseline characteristics. They are quite comparable between nivo-epi versus placebo, and these are the disease-free survival. Definitely, it is a negative trial, and as you see here, the two curves are overlapping each other. The hazard ratio of 0.92, and the 2-year disease-free survival for nivo-epi is 76.4%, and the placebo is 74%. Also, the disease-free survival by the investigator, again, the hazard ratio, it is the same, 0.92, with the 2-year disease-free survival, 77% versus 74%. These are the subgroup, and definitely here, who benefit from the nivo is those with sarcomatoid features and those with positive lymph nodes. These are the safety and summary. We have here a very high percentage who discontinued the treatment due to the study drug toxicity, which is 33% in the nivo-epi versus 1% in the placebo. So definitely it is a tough combination to be bringing as an adjuvant treatment for patients who are asymptomatic. The only is that have a high risk, you can go for this combination. The CheckMate 914, we have a treatment-related adverse events, and as I mentioned before, we have definitely diarrhea, we have elevated liver enzymes, and we have some adrenal insufficiency. However, as you see, the placebo, almost the grade 1 and 2, and very dismal. These are the immune-mediated adverse events, and definitely we have diarrhea, colitis, adrenal insufficiency, hepatitis, thyroiditis, and some pneumonitis. And definitely the usual treatment is corticosteroids of 40 milligrams per day or equivalent to manage such immune-related adverse events. And definitely 23% of the patients use corticosteroids at a dose of more than 40 milligrams per day versus the placebo, 2% only. So my third take-home message, that the reasons for failure of the IM motion 10 with Atezo and the CheckMate 914 with Zenivo and the Prosper trials still are unclear and could reflect the difference in patient population, such as the proportion of patients with very advanced or resected metastatic disease, the different mechanism of action of the respective immunotherapy agent tested, or differences in follow-up times, and the subgroup analysis using all the data from the 3 phase trials are important to tease out which patient will have the most benefit and to investigate the absence or presence of predictive biomarkers, especially that the PD-L1 is not good as enough. So the final take-home message for the neoadjuvant and the adjuvant therapy in RCC is that we have a heterogeneous design of recent perioperative and adjuvant RCC trials, and difference in patient population make conclusion very difficult to draw. However, we can consider adjuvant pembro as a collective decision for patients with clear cell RCC with pathologic T3 or higher disease and T4 and positive lymph nodes, and definitely the M1 NED within 1 year. Still, we have unanswered questions about the duration, although the most common is to use the adjuvant therapy for 1 year, the intensity, and the risk benefits concerning the side effects. And thank you very much for your kind attention.